Hello, everyone, and welcome to the Anesthesia Podcast. Today, we're going to explore some exciting new research findings on postoperative cardiovascular complications, as well as discuss the fascinating world of collaborative research networks. My name is Maryann Turner, and I'm an editor at Anesthesia. I'm recording from Naarm, Melbourne, from the lands of the Boon Wurrung people, and I acknowledge their elders, past and present. I'm excited today to be joined by Savesh, Yeva, and Omar, who are all involved with the STARSurg and EUROSurg collaboratives. They've recently completed an international prospective cohort study on the impact of postoperative cardiovascular complications on 30-day mortality after abdominal surgery. I'd like to invite the authors to tell us a little bit about themselves and the role that they played in this study. I'd like to start with you, Savesh.
Hi, everyone. My name is Savesh. I'm currently a surgical trainee and I'm undertaking a PhD in Birmingham, funded by the NHR, on multimorbidity and surgery. During Cascade, I was co-chair and co-led this collaborative across 446 hospitals in 29 countries across Europe. And I'm really pleased to be here and join the discussion on the paper today.
Thank you so much, Savesh. It's so lovely to have you. Yeva, would you like to go next?
Hi, everyone. I'm Yeva Yakitita, a medical student, final year medical student from the University of Exeter. I've been part of STARSurg for the last 2.5 years now, and I've really enjoyed my time there. And sorry, the reason I joined STARSurg actually was because I was in an operating theater with a surgeon, and I mentioned that I'm interested in surgery, and the only question they asked me is, "Are you part of any national collaboratives?" So I think it's a great opportunity to get involved in research as a student, and I've been here for all these years because it's been such a useful time for me.
And what an amazing reflection on what good work the collaboratives have already done, that a consultant surgeon is, encouraging you to get involved. That's wonderful. Omar, would you like to introduce yourself?
So yeah, I'm Omar Cooley. I'm a neurosurgery trainee at Sheffield, and I was the immediate co-chair and co-led the study with Savesh. And I've been in STARSurg for the past, well, 8, 9 years now. So it's been a long time, but I really enjoyed my time there, and it's a pleasure to be presenting this work here today.
Oh, no, thank you so much all. I know how busy it can be for both students and trainees and junior doctors. So we're really grateful for your time, and we're really looking forward to learning more about your paper and about your collaborative. So let's start with that. So tell our viewers or our listeners a little bit more about EUROSurg and STARSurg and all the good work that you've been doing.
So STARSurg was created by a group of medical students, trainees and consultants who wanted medical students to lead impactful research. And they saw the potential in their peers in terms of time and drive to complete research projects. And so they wanted to unite them in a national collaborative to complete national projects. And the STARSurg model is really based on collaboration and shared ownership of all the projects, which I think has been the drive behind the success of STARSurg, really. And so we just celebrated our 10-year anniversary in November 2023. And over the last 10 years, we've completed around 8 projects and published 44 papers, and the largest of them being Cascade, which kind of was our the thing we aimed for, I guess, in terms of we had close to 5,000 collaborators and over 24,000 patients recruited to the study. And based on the STARSurg successful model, we helped create EUROSurg in Europe. So STARSurg is mainly focused in the UK, and we recruit UK medical students. And EUROSurg is kind of a reflective model in Europe. And together, we collaborate on multiple projects, such as Cascade, but also our recent study, Apollo.
Wow, that is just so amazing. Tell me, have many people gone on to then do, does this trigger a career in research for a lot of people involved in these projects as more junior doctors or students?
I think,
yeah, go for it. I think just a quick reflection on how big collaborative research is. From a very personal view, I came from Syria about like 10 years ago, and like very little English, don't know anything about research. And I was like, where do I start? What can I do? And really, the first thing that I seen was STARSurg, and I was like, okay, let me see what it's all about. And really, it teaches you a lot about how methodology works in research, how to build yourself from collaborator to hospital lead to regional lead to a committee member, and to design these studies. And like it really pushed me and allowed me to network with a lot of like-minded individuals. So really, like collaborative research is, for someone who doesn't know where to start, it's a very good starting point, for anyone really.
And how did you get involved, Savesh? Did you talk us through your pathway?
Yeah, I'm sort of walking memory lane as Omar and Yeva were talking about theirs. So I started back in 2016 as a medical student. I think I was third or fourth year. I initially was involved with EUROSurg at the point when they first started, and then joined in as the STARSurg as part of the steering committee, being involved in sponsorship coordination and gathered quite a bit of money. And through then I've been involved as a student lead, and then moving on to chair. And it's been probably 10 years since I've started. So it's definitely been a long trajectory. And I think, as Omar and Yeva said, it's a really good platform to be involved in future research. And I think STARSurg is really pushing boundaries now, which Yeva will come on to later in this podcast. But it's really been quite the journey, and I've certainly learned a lot from the process.
And it sounds like it's relatively easy to get involved. Is sort of, how do people find you, and how do people, get started with these collaboratives?
So traditionally, we often sort of open for steering committee roles each year, and we often have a selection criteria of if people have been involved in research in general, have they been involved with STARSurg, and what is their aspirations and motivation to join STARSurg, and then we shortlist applicants, and we have an interview with a panel of STARSurg steering committee members to really understand who the applicant is and why they're keen to join. And we select a handful of them, and over the year we sort of see how people progress through, and some people stay on, and understandably some people move on for a lot of reasons.
Oh,
And in terms of the very first kind of the first step of getting involved in STARSurg, we have a wonderful group of regional leads, which we recruit in a similar fashion to a committee. And they represent STARSurg in every medical school across the UK. And so the medical students are able to sign up to participate in our projects through the regional leads.
Great. Gosh, it sounds like, and I mean, obviously the UK wasn't enough, so you had to go, multinational. So that's wonderful. And tell me about this. So this latest study that you've done, you've got so many hospitals involved, and obviously so many collaborators. Can you tell me a bit more about this this latest study that you're doing, that we're publishing, and how did you make it happen?
So I think in terms of how to manage to put this large group of researchers together, as Eva said, STARSurg and EUROSurg have been operating for the past 10 years. In this time, we've built a lot of and acquired an extensive network of committed researchers. And most importantly, we learned a great deal of how to upscale studies to make them like large and multinational, and especially how to use technology in our advantage. So Cascade is our largest study yet. And I think the key factors of why it was very successful is that we invested a lot of time in the election and the guidance of national leads. So every country in Europe, we had a national lead that represents STARSurg, who supervised hospital leads and ensured that the data was complete and accurate. And so that means that queries were answered around the clock. We had WhatsApp groups and emails to help collaborators and hospital leads with any queries. And we also hosted multiple webinars every fortnightly that allowed us the collaborators to be in the loop, and made sure that we updated all our websites and social media platforms accordingly. And where we put like sort of like technology, we've used Shiny apps, like they're like live dashboards that the researchers can access. They can check what is missing from their data, what is left to do, and the progress, which meant that even the data collectors, the hospital leads, national leads, everybody was in the loop, and everybody was well informed of what is going on. And really, the most important thing is that, and this is me thanking all the collaborators and hospital leads, national leads. It's all down to their perseverance and commitment that led to the success of the study.
It's just amazing. Tell everyone again how many hospitals and participants you had involved.
So we had 445 hospitals from 29 countries across Europe, and over 5,000 collaborators.
Wow. Congratulations. That is just such amazing, amazing work. Now, tell us a little bit more about what you found. What were your research findings from all of this amazing work?
Yeah, so I think we set out to understand what the impact of postoperative cardiovascular complications are in a modern era. And the rationale for that really is, we've got an aging population, increasingly multimorbid, and we don't really have much of a contemporary data. And, as surgeons and preoperative care physicians, we're always trying to increase the quality of the pathways for these patients. And we wanted to really look at postoperative cardiovascular complications. So trying to link the two together, the most important finding we think in this paper is the relationship between cardiovascular complications and postoperative death or mortality. And it was shown that postoperative cardiovascular complication was attributable to 20% of deaths, which is quite a staggering amount, thinking about the different types of cardiovascular complications we captured, such as atrial fibrillation and also myocardial injury, which has in recent years created a lot of debate. So we wanted a contemporary cohort across the UK and Europe to provide benchmarking data for us to generate a research agenda moving forwards in this space.
Were any of the findings particularly surprising to your group?
I think one of the things was the high volume of mortality that was attributed to postoperative cardiovascular complications. And where we dug in deeper into the etiology of it, myocardial injury was very, very much important. I think the other thing to point out here is that the rates that we found was about 3% to 4%. And one might argue that, the rates are fairly low. And I think one of the key things to think about as we discuss this paper is that routine troponin was not done in a lot of these patients. So there's potentially a risk that we've not really captured all of them. But even despite that, the rates are quite high in terms of how much is attributed to mortality, which will, it really poses questions as to, should we really be doing troponin on every single patient that comes through the preparative pathway, or is that going to cause us more problems than we actually can solve? So I think it does raise an area of discussion for the community as we chat through the paper and as the paper comes out.
Yeah, how wonderful. And tell me, the definition of cardiovascular complications, seems a reasonable amount of confusion around this previously. Talk us through why you chose the definitions, what definitions you chose and why.
So one of the things was when we were setting up the study, the STAP compact definitions came up, which set up a consensus process. It was published in the British Journal of Anesthesia, looking at how can we better design future clinical trials so that we can have standardized endpoints that is meaningful to not only patients, but to clinicians and academics delivering high quality research. And they set out about 7 to 8 different measures, including atrial fibrillation, myocardial injury, myocardial infarction. And using those composite measures, we designed a study. Now, one of the main areas of confusion has really been about myocardial injury, owing to the different types of definitions that have been used in terms of the different types of assays that have been used, which has created a large amount of data. But stepping back away from that, we really aim to really define what the rates using a more recent definition that was set out using the STAP compact, which is different to the groups that I've used, and really just to seek out what the relationship is with mortality.
Yava, did you have anything to add?
I think actually Sebash covered it perfectly. Yeah, so the STAP compact paper was the consensus was reached through a meticulous process, and so we trusted the consensus definitions, and they allowed us to kind of evaluate the incidence of PCCs and their association with mortality based on a standardized measure, meaning that hopefully in the future the values, the incidence would not be as variable as previously seen in different reports.
And tell me, sort of what do you think, given the causal relationships between the relationship between cardiovascular complications and postoperative death, what are we gonna do about it? How can we stop these deaths or minimize, reduce the number of deaths in the future?
So yeah, so as Savesh said, is if we prevent, in a scenario where we prevent cardiovascular complications, we save one in 5 deaths. We prevent 1 in 5 deaths from occurring, and that's huge. So how do we sort of like optimize these patients to prevent these complications? And really, it's not just optimizing the physical conditions for surgery, but also the psychological and social conditions. And it stems from it's not one point, but it's multidisciplinary rehabilitation programs that focuses on diet, the mental health of patients, the exercise, but also, and this is like part of what Cascade has been looking at. We collected data on a lot of risk factors, so including smoking cessation, how long do you need to stop smoking, and treating anemia. I think this has been touched in the previous podcast here, and in anesthesia, and how to treat anemia preoperatively, intraoperatively, and postoperatively, and how to see what patients are at greatest risk, and especially those who have more than one long-term conditions, or as in like multimorbidity. So these are the stuff which actually we are going to look forward. So not to spoil a lot of what's gonna come out from this paper, but in terms of smoking cessation, anemia treatment, looking at patients with multimorbidity. So yeah, it's very exciting on how to prevent these deaths from occurring.
Tell me, will your collaboratives be looking into these sort of smaller areas or doing further analysis into these areas?
Yeah, so these will be part of the secondary analysis of Cascade that we're working on currently. And it's part, but that's why the Cascade data set is huge, the data we collected. So, and that sort of like how to prevent cardiovascular complications from occurring. We are looking into these specific risk factors.
Excellent. So the rest of us will be able to grow old knowing that the future of our cardiovascular outcomes is in good hands. Tell me, did you find any limitations in your study? What did you identify as possible issues? Sorry,
I think most of the limitations we anticipated ahead of our study, actually, mainly because we were collecting routine data, so there wasn't a change to clinical practice that we introduced. And so that meant that if the complication was not recognized as part of, routine management of a patient, it would not have been recorded in our data set. And this is very important for complications such as Vash mentioned, myocardial injury, but also new onset AF and VTE. So we expect that the rates of the incidence of these complications might have been underestimated in our data set. However, we expect that the more serious complications were estimated correctly. And in a similar vein, collecting routine data meant that we were limited in terms of the risk factors that we were able to collect data on, because we wanted the data to be available across Europe. And so there might have been some, we know of some risk factors that we might have not been able to collect that are known to be associated with postoperative complications. And lastly, it was the time of COVID that the data set was collected. And so it is still a bit unclear of whether that had an impact on our outcomes as well.
Do you think you would do anything differently if you were doing this study again? Would you change anything?
I think these limitations are kind of unavoidable. So I think we were quite happy with our approach, and we worked really hard to kind of make it as right as possible for our outcomes, if that makes sense.
Yeah, absolutely. No, it's I can't even imagine the difficulty, working with so many different countries and languages and assays and whatnot. Like it, yeah. No, it's amazing that you've managed to pull all that together and during COVID. Goodness. Now you talked briefly about sort of what future studies might flow from this study, and obviously there's the ones that to do with your secondary analysis, but bigger picture, what do you think other groups or researchers could be, what will this study inform?
Yeah, no, I think it's definitely posing a question more than it's posing a solution in terms of this paper. And I think the bigger pictures, we often think about, as a surgeon, we always think about how can we improve techniques and how can we improve outcomes within the operating theatre. And a lot of it's often marginal gains. And often we forget the bigger picture that is for the patient is to how can we improve their experience? How can we improve their pathways to reduce complications? And this is where things like cardiovascular and pulmonary complications come in. But broadly, I think, there is a lot of things going on in a public health setting to try and address larger risk factors that can improve quality of life for patients. And we know that with an aging population, with people having more multi-morbidity, there is definitely an urgent call to action for us as surgeons and preventative care physicians to address the larger elephants in the room. But we currently don't know how best to do that. We address things like rehabilitation, which focuses on exercise and strength conditioning. We think about rehab after that. But in the space of, optimizing people's multi-morbidity, how can we better integrate care? We don't really know. So the aim of Cascade, what it aims to paint is actually there is a problem with a more contemporary cohort of aging society. And we really need to think about trials that can better address them. So we know a trial to address how can we better integrate multi-morbidity into routine care such that it's everyone's responsibility and it's sustained throughout the perioperative period. That would be one large question. How do we integrate with, smoking cessation efforts in across public health? For instance, in the UK, we've recently launched a smoke-free generation campaign. And how can surgeons and perioperative care physicians play a role to engage in such activities? So trials around behavior change to try and target some of these would be very much what we would think would be the direction of travel. We're trying to rally a group of surgeons and perioperative care physicians across the world and across the country is often quite challenging. But I think that's where the hope and travel should really be coming up from this research.
The perioperative space is so multidisciplinary, isn't it? Like it literally, as you alluded to, starts with the primary healthcare providers and can work, all the way through. It's such a big group, but I guess that's why these collaborative efforts are just so important. You've sort of spoken a little bit about the secondary analysis of still to be done with this work, but tell me a bit about the future of STARSurg and EUROSurg. Do you have any big projects on the horizon, or where to from here now that you've got this one under your belt?
Yeah, so we're very excited to announce our upcoming study, which is the first trial that STARSurg will be co-leading. And its name is Clarity. And it will be looking at surgical education to reduce negative appendectomy and enhance patient outcomes is the name of the study. And so we are joining in partnership the West Midlands Research Collaborative. And the trial is set to assess the effectiveness of an educational intervention on reducing non-operative admissions and also negative appendectomy rates in patients, which is quite a big problem in the UK.
And will this just be a UK-based project, or are you going big as well?
So this project will be based in the UK, just because it is a trial. So we need a really close monitoring of our centres, and yeah, it is a big undertaking for a student-led collaborative. So it is the first step, hopefully, into what we will be doing more often in the future.
Yeah, the big world of RCTs. That is such amazing news. Congratulations. I think that's just wonderful. And I hope that, you can get lots of people recruited, and we'll be seeing your paper and then it come out on the next project in the next few years, as well as some of your secondary analyses as well. That's just wonderful. Thank you all so much today for talking to us and sharing all your work. Did anyone want to say anything to finish off? Was there anything that you wanted to draw our readers' attention to?
Nothing, just say thank you for taking the time to do this webinar. Really appreciate it. Thank you very much, Maryann.
No, thank you all. So we'll wrap it up there. Thank you so much for your time. I understand how busy you all are. Congratulations. Like, this is just such amazing work. I'm really looking forward to our listeners to read the paper. The paper will be published on the same day this podcast is released. So everyone can jump online and have a read of your paper at that time. So thank you very much. I'd like to thank Mike Charlesworth as well, the social media editor of Anesthesia, for helping us set up this podcast and helping with the organisation. And I just really want to encourage all of our readers and listeners to have a look at this paper. And I wish all of you and your collaborations the very best going forward. Thank you so much.